I'm Joe Graydon.
And I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy.
You can find previous podcasts and more information on a range of health topics at peoplespharmacy.com. Have you ever taken Prevacid or Prilosec? Millions of people take acid-suppressing drugs daily. Are there unexpected side effects? This is the People's Pharmacy with Terry and Joe Graydon.
Do proton pump inhibitors affect our cardiovascular system as well as our digestive tract? How important is your microbiome in maintaining good health? We'll find out how to nurture the bugs in your belly.
We're talking with Dr. Robin Chutkan, author of The Microbiome Solution. She'll tell us how inflammation affects our overall health and what we should know about leaky gut syndrome. What does Dr. Chutkan mean when she says live dirty, eat clean?
Coming up on the People's Pharmacy, how to have good digestion without drugs.
First, this news.
In the People's Pharmacy Health Headlines, people with low vitamin D levels may benefit from increasing their magnesium intake. At this time of year, vitamin D levels are dropping due to limited sun exposure, but supplementing with a vitamin D pill may be less effective for people with low levels of magnesium. According to the National Health and Nutrition Examination Survey, 79% of adults in the U.S. don't get the recommended dietary allowance of this mineral. A randomized controlled trial of 250 people compared magnesium supplements to placebo. The dose of magnesium was individualized to compensate for dietary intake. Among people with high levels of vitamin D, magnesium supplements tended to lower them. On the other hand, magnesium supplements boosted vitamin D levels in people who started out low. The researchers concluded optimal magnesium status may be important for optimizing vitamin D status.
A weekly whole-body massage sounds like a luxury, but new research suggests that it could help people with knee arthritis live with less pain. Investigators recruited 200 patients with osteoarthritis of the knees. One-third of these people received a 1-hour Swedish massage session every week for 8 weeks. One-third got a light touch treatment to serve as control, and the final third received no additional treatment beyond their usual care. They responded to a standardized questionnaire designed to measure arthritis symptoms. Those receiving massage reported significant improvement in their pain and stiffness. One advantage of massage over medication: no side effects were reported.
People who take statins to lower cholesterol may be more vulnerable to back disorders. Researchers used a military insurance database to compare patients taking statins with a matched set of controls not on such medications. There were 6,728 individuals in each group. They were followed from 2003 through 2012. The researchers found that people who used a statin for at least 4 months were 27% more likely than non-users to be diagnosed with a back disorder during this time. Such disorders include spinal problems such as spondylosis and intervertebral disc disorders. The author suggests that statin use might contribute to the muscle pain often associated with these back problems, but they warn that the data from a military population might not translate perfectly to other groups of patients. Critics of the study state that such observational studies create confusion for patients and physicians. They point out that the randomized controlled trials sponsored by drug companies did not detect a higher risk of back disorders associated with statin use.
Barrett's esophagus is a condition in which the tissue lining the bottom of the food tube changes to resemble tissue lining the intestines. It's considered a precancerous condition and is often associated with acid reflux. New research suggests that a very old drug might help prevent Barrett's esophagus from turning into esophageal cancer. That drug is aspirin. Although aspirin can be irritating to the digestive tract, it blocks an inflammatory pathway thought to play a key role in cancer development. This research complements epidemiological studies suggesting that aspirin use reduced the risk of esophageal cancer.
Health professionals have been telling people for decades that full-fat dairy products such as milk, cheese, or yogurt are bad for the heart. The saturated fat in such products was thought to clog coronary arteries. That's why skim milk and low-fat yogurt and cheese have become so popular. A meta-analysis published in the European Journal of Epidemiology suggests that advice might have been misguided. The authors analyzed data from 29 studies over the last 25 years. Nearly 1 million subjects were included in these trials. The investigators found no link between the consumption of milk or dairy products and heart disease or death. It didn't matter whether people consumed high or low-fat dairy products, there was no increase in mortality. The investigators even detected a slight trend toward a lower risk of heart attacks or strokes among people consuming fermented dairy and cheese products. Perhaps admonitions to avoid dairy products high in saturated fat need to be reconsidered. And that's the health news from the People's Pharmacy this week.
Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. Millions of people take proton pump inhibitors like Prevacid, Prilosec, or Nexium every day. These powerful acid-suppressing drugs are extremely effective at controlling symptoms of heartburn. They can also help heal stomach ulcers. But questions have been raised about the long-term safety of these medicines. Do they have unexpected cardiovascular consequences?
To help us answer that question, we turn to Dr. Philip Gorelick. He's the medical director of the Hauenstein Neuroscience Center, St. Mary's Healthcare in Grand Rapids, Michigan. He's a professor of translation science and molecular medicine at Michigan State University and is a speaker for the American Heart Association.
Welcome to the People's Pharmacy, Dr. Philip Gorelick.
Hello there. Thank you.
Dr. Gorelick, we understand that there's been a recent study linking proton pump inhibitor use to an elevated risk of ischemic stroke. So first, if you don't mind, tell us a little bit about proton pump inhibitors. They're widely used. They're available over the counter. Probably millions of people took a PPI today. And how in the world could a heartburn medicine have an impact on the vascular system?
Well, isn't that very interesting? There have been some basic science type studies done, and what these drugs seem to do is inhibit nitric oxide synthase, which is something we need to keep our arteries healthy, and in the process, it causes elevation of a substance called ADMA. And ADMA stands for asymmetric dimethylarginine, and this is a substance that has been shown in animal models anyway to be atherosclerotic inducing. There have been some other ideas that have come around that the PPIs as a group might also affect the inner lining or endothelium of the blood vessels and cause the endothelium to dysfunction. The endothelium is a barrier that keeps the blood system healthy, and if that barrier gets penetrated, and because it's dysfunctioning, it can lead to hardening of arteries. And so these researchers in Denmark went and looked at a national registry study and found some very interesting findings.
Tell us about what they found.
Well, they were wondering, could these PPIs pose a risk of ischemic stroke, and would that be the case for the general population? And they looked at records of over 240,000 Danish patients. Their average age was about 57 years old, and they had had a procedure, an endoscopy, which is used to look for ulcers and is sometimes done when there's stomach pain or indigestion. And when they followed this group out almost 9,500 people had an ischemic stroke for the first time. And what they found was that a number of them were using the PPIs, and the ones that they looked at were omeprazole, which is also called Prilosec in the U.S., pantoprazole, which is also called Protonix, lansoprazole, which is Prevacid, and esomeprazole, which is Nexium. And they showed that the overall stroke risk increased by 21% when patients were taking a proton pump inhibitor. However, at the lowest doses of these PPIs, there was only slight or no increased stroke risk, but at the highest dose, the stroke risk increased anywhere from 30 to 94%. So that's quite striking, and if you have a chance, or your audience does, to look at the graphs, you see very nicely that with each of these drugs, the low doses, and those were generally either 10, 20, 15 milligrams of these individual drugs did not cause an increased risk of stroke. But once you cross to the next dose, which was 10 or 15 milligrams higher, sometimes 20 milligrams higher and up, you would see this stepwise increase in stroke risk. So this is something people need to pay attention to, and they need to say to themselves, should I really be on this proton pump inhibitor at this time? And of course, they need to check with their physicians, and as you've already mentioned, do the physicians know about this association between the proton pump inhibitors and possible increase in stroke risk?
Dr. Gorelick, it's my understanding that there was a prior study suggesting an increased risk of heart attack, presumably by the same mechanism. Is that right?
Yes, I believe that is correct.
So the question then becomes one of, what about people who already have endothelial dysfunction, that is to say, not very flexible arteries, people who perhaps have had a diagnosis of heart disease, have had a stent, maybe even a heart attack or a TIA, a transient ischemic attack. Would they be more vulnerable?
Well, there's several things to consider here, and probably one of the most important is your lifestyle factors and your general cardiovascular factors. As I previously mentioned, hypertension, diabetes, smoking, physical activity, obesity, and some of the other factors are associated with the endothelial dysfunction. So anything you can do to try to prevent the endothelium from dysfunctioning would be important. And so controlling your cardiovascular risks is very important, whether they're lifestyle factors or traditional factors such as hypertension, cigarette smoking, diabetes, and so forth.
Dr. Gorelick, it sounds as though people who have stomach trouble, who might also have some heart problems, should really be talking to either a primary care doctor who could serve as the traffic cop, as it were, or should be talking to both their gastroenterologist and their cardiologist about everything they're taking to make sure that they're not going from the frying pan into the fire.
Yeah, I think that's a good analogy. I like that, and I fully agree with you. I think the first thing is being empowered with knowledge and understanding that there are a number of drug-drug interactions that can occur, and knowing about these associations, such as with the proton pump inhibitors and ischemic stroke risk. Once one has that knowledge in hand, I would suggest that they stop first with their primary care doctor. Start there, see what the primary care doctor has to say. If you don't feel satisfied, then you have to take it up the chain, and you may have to consult a gastroenterologist in addition.
Dr. Gorelick, a lot of people take over-the-counter pain medications, ibuprofen, naproxen. They're available like Advil, Aleve. And, they've got arthritis, so they're taking these drugs on a daily basis, not just for days or weeks, but months and years. And, of course, one of the most common side effects of these drugs is stomach upset, indigestion, heartburn. And as a result, they may reach for the proton pump inhibitor, the Nexium, the Prilosec, the Prevacid, that they can also buy over the counter. Well, it turns out we've heard in the last couple of years that NSAIDs, like ibuprofen or naproxen, may increase the risk of heart attacks and strokes all by themselves. And so now they're also taking a PPI to counteract the stomach upset, and it too may have an effect on heart attacks and strokes. So now you're taking two different categories of drugs that may independently increase your risk of a heart attack or a stroke. That seems scary. Your thoughts?
Well, we have this discussion in the office once we identify what these drug interactions are and the risks, and then the patient and their significant other or caregiver help me make a decision about what would be best for that individual patient. But I'm looking for substitute drugs if I can, other things that don't have these risks. And that's really how I've been managing these patients in my office. So it's identifying what the risks are, having a discussion with the patient and the caregiver, and then making a decision that we think is best for the patient. But a lot of times it comes down to using different drugs that hopefully won't have these side effects or other side effects that would be deleterious to the patient.
Dr. Philip Gorelick, thank you very much for talking with us on the People's Pharmacy today.
Thank you.
You've been listening to Dr. Philip Gorelick. He's the medical director of the Hauenstein Neuroscience Center at St. Mary's Healthcare in Grand Rapids, Michigan. He's a professor of translation science and molecular medicine at Michigan State University, and he's a speaker for the American Heart Association.
Terry, it's important to recognize that proton pump inhibitors have a really important place, but they do have some side effects, not the least of which include infections like pneumonia. Then there's the malabsorption. People don't absorb magnesium as well as they should, or perhaps even vitamin B12. There's a risk of fracture. There's a risk of kidney damage. There's a risk of heart attacks. But no one should ever stop any prescribed medication except under medical supervision.
Well, and if you were to stop a proton pump inhibitor suddenly, you might have horrible heartburn because there is a rebound hyperacidity.
Exactly. And that's why it's important to discuss the pros and cons of proton pump inhibitors with your prescriber before you take any action. I mean, there's certain situations where you absolutely have to take a PPI. After the break, we'll talk more about PPIs and their effects on the heart.
Our gastroenterologist knowledgeable about non-digestive side effects.
How effective are these drugs for Barrett's esophagus?
We'll find out what Barrett's esophagus is and whether these popular pills can prevent it from turning into esophageal cancer.
We'll also learn about something called SIBO, or SIBO, S-I-B-O. What effect do antibiotics have on bacteria in the small intestine?
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you value the health information you get when you listen to The People's Pharmacy, consider subscribing to our email newsletter. You'll get the latest health news and information on upcoming podcasts delivered to your inbox twice a week. Look for the link at peoplespharmacy.com. Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Red X Industries, makers of utterly smooth creams and lotions that deeply moisturize to make dry skin feel soft and smooth. 800-345-7339, online at uttercream.com.
If you would like to order a CD of this show, you can call 800-732-2334. Today's show is 1078. The number again, 800-732-2334, online at peoplespharmacy.com.
Today we're talking about your digestive tract. Have you ever taken a proton pump inhibitor such as Nexium or Prevacid for heartburn? How safe and effective are these popular medications? What else can you do for digestive distress?
To learn more about keeping your gastrointestinal tract healthy, we turn now to Dr. Robin Chutkan. She's on faculty at Georgetown Hospital and is the founder of the Digestive Center for Wellness in Chevy Chase, Maryland. She did her medical training at Columbia and is board certified in gastroenterology and is the author of 3 books, Gut Bliss, The Microbiome Solution, and The Bloat Cure.
Welcome to the People's Pharmacy, Dr. Robin Chutkan.
Thank you so much for having me, Terry. It's a pleasure to be with you today.
Dr. Chutkan, we'd like to follow up, if we may, on this concept of proton pump inhibitors. You are a gastroenterologist. Your colleagues love these drugs. Millions of people take a proton pump inhibitor, a PPI, every day to ease their heartburn, their reflux, their GERD, whatever you want to call it. And yet, maybe these drugs are not quite as safe as we used to think they were. The FDA thought they were so safe they made them available over the counter, and I have no doubt that people are popping Nexium 24-hour, Prilosec and Prevacid almost as if they're candy. So the question is, from a gastroenterologist perspective such as yours, what about these drugs and some of the cardiovascular risks that we've heard about, stroke, heart attack, etc.?
What I'd like to remind people is that none of these pharmaceutical cures, if you will, are free. They all come with a risk. They all come with a downside. And as you said, my gastroenterology colleagues have been prescribing this stuff like water. I mean, I think most of my GI colleagues think it should be in the water. And to be fair, for a long time, I think most gastroenterologists were completely unaware of the downside of proton pump inhibitors. It's a little bit of that magical thinking that happens in medical school where you think this is all good and there's no downside. But the news is not good. So not just in terms of cardiovascular risk and damage to the kidneys and potential contributions to dementia and increased fracture risk and poor absorption of magnesium and B12, but to our gut itself in terms of that very important community of microbes that live in our GI tract and are incredibly important for our own health. We also know that proton pump inhibitors have a profound and negative effect on that. And we see that manifest as an increase in infection, an increase in common infections like Salmonella and Shigella, as well as a sort of infection called Clostridium difficile, C. diff, that's associated with antibiotic use. So being on a proton pump inhibitor chronically can increase your risk quite dramatically for a number of different problems.
Now, I would think that the gastroenterologists might actually be paying attention to these intestinal infections, whereas they might be perhaps oblivious or not paying such close attention to things like an increased risk of fracture because they don't see that. That's not when they see the patient.
That's right, Terry. And, we're very compartmentalized in the medical world. So if my specialty is the pinky finger on your left hand, that's sort of what I'm singularly focused in. And this concept of a more integrative approach to medicine is looking at the whole body and looking at the way things interact with different organ systems is still relatively new in the medical community, unfortunately. But you're right, there has been a lot of attention on this concept of not just GI infections broadly, but specifically Clostridium difficile infection, which is a bacteria that is often present in very sort of low amounts in people. Some of us are colonized with it at birth, particularly if we're born in hospitals. But in the presence of an antibiotic, which destroys a lot of your healthy bacteria, the C. diff then proliferates, the way yeast can proliferate after a course of antibiotics, and you can end up with a yeast infection. So the C. diff proliferates, or you're exposed to it from somebody, say you're visiting someone in the hospital who has it. Then you yourself take an antibiotic, kills off a lot of your peacekeeping healthy bacteria, if you will, and the C. diff really proliferates. And being on a proton pump inhibitor is a major risk factor for ending up with a C. diff infection if you're exposed to it. So because C. diff is within our purview, and it's something that we treat as gastroenterologists, we're very aware of the C. diff PPI, proton pump inhibitor connection, so much so that it has, and I think this is a very good thing, it has affected the guidelines. So when people get admitted to the hospital, and there used to be almost a sort of rubber stamp of, oh, let's give this person a proton pump inhibitor just in case. And now, because of the proliferation of C. diff infection in hospitals, we're much more judicious about not giving somebody a proton pump inhibitor just because, unless they have a clear indication. So that's one area where I think we have seen some changes in practice for the better. We're starting to. But I think there is still, there's still this sense that a proton pump inhibitor is just a good, easy way to potentially get somebody feeling better. And ironically, proton pump inhibitors not only can cause or increase your risk of something like C. diff, they're also one of the top factors for developing something called SIBO, small intestinal bacterial overgrowth.
Well, Dr. Chutkan, before we talk about SIBO, and I really want to talk about that, I'd like to ask you about something called Barrett's esophagus, because you talked about the guidelines. Most gastroenterologists, your colleagues, believe that they absolutely must prescribe an acid-suppressing drug like Nexium or Prilosec if someone is diagnosed with Barrett's esophagus to prevent that from turning into esophageal cancer, which is a bad actor. So first, can you tell us what Barrett's esophagus is? And number two, how effective are proton pump inhibitors in preventing Barrett's from turning into esophageal cancer?
Two great questions. So let's start with the definition of Barrett's. Normally, in the normal healthy state, the cells lining the esophagus are squamous cells. And when we do endoscopy, those squamous cells, that esophageal lining, look sort of a pale pink color. When you get to the gastroesophageal junction, which is the area where the esophagus meets the stomach, the first thing you notice is that the lining of the stomach is sort of a beefy red compared to the pale pink of the esophagus, and that's because it's a different kind of lining. In the stomach, we have specialized a columnar epithelium that is specialized in the sense that it can handle the acid of the stomach. So remember, in the normal state, the esophagus is really not seeing any acid. Food gets chewed up in the mouth and it gets swallowed and it travels with the help of gravity and peristalsis, the sort of wave-like contractions through the esophagus. It hits the stomach, and it's in the stomach where it continues to get churned up, and that's where it first gets exposed to acid. So what happens with Barrett's esophagus is that squamous lining, that pale pink sort of delicate lining of the esophagus, goes through a transformation called intestinal metaplasia, and it turns into specialized columnar epithelium. So it starts to look more like the stomach. And in fact, that's exactly what it looks like to us when we do endoscopy. We see this sort of tongues of stomach-like lining, stomach-like mucosa, red, more beefy colored mucosa coming up into the esophagus. And we have short segment Barrett's esophagus, which is generally less than a couple centimeters. And then we have people with long segments of Barrett's, where the lower part of the esophageal lining is essentially replaced with a specialized columnar lining. About 10% of people with chronic gastroesophageal reflux disease will develop Barrett's esophagus. And you are absolutely right, where that was sort of our mantra in gastroenterology, is if somebody's diagnosed with Barrett's esophagus, they absolutely must be on a proton pump inhibitor for life. And one of the interesting things in medicine is that as practicing physicians, we just sort of acquire this information and we don't really question it. It is just sort of handed down from on high. And unfortunately, it is often handed down by key opinion leaders who are selected by the pharmaceutical industry, who are groomed by the pharmaceutical industry, who are financially supported by the pharmaceutical industry to disperse this information. And so there's a tremendous amount of indoctrination, if you will, going on that we're not even aware of. And often when you trace it back, this sort of irrevocable guideline that is set in stone is based on very, very little information. It's based on one or two studies with spurious results. And so there was a meta-analysis that was published at the beginning of this year, which looked at essentially all the studies that have been done, and they had very strict criteria for which studies they would actually use, studies that they felt were scientifically robust and could really answer this question. And the simple question they asked was whether proton pump inhibitors reduce the risk of esophageal cancer in patients with Barrett's esophagus, because that's a very foundation on which this idea of treating with PPIs for life was built. It's the idea that if you have Barrett's esophagus, you are at increased risk for esophageal cancer, and that suppressing acid essentially for life would somehow mitigate that risk, decrease your risk of developing esophageal cancer. And when I tell you, this was one of the fundamental beliefs in gastroenterology. This was something that nobody questioned. So it was fascinating when this meta-analysis came along. It was done by a group in China and a group right here in our area at Johns Hopkins, and they looked at all the data, but they narrowed it down to these 9 what they felt were very scientifically robust studies. And these 9 studies comprised almost 6,000 patients. It was about 5,700 patients. And they looked at whether there was a relationship, a trend even towards protection against esophageal cancer or high-grade dysplasia, which is sort of the precursor lesion to cancer, with people using proton pump inhibitors for more than 2 or 3 years, which should definitely be an adequate amount of time. So they weren't just looking at people who were taking a proton pump inhibitor for a month or 2. They were looking at people who were on it for years. And astoundingly, they found no trend towards protection. So this completely has turned on its head what has been up to now one of these central tenets in gastroenterology, that you must use a proton pump inhibitor, and that it is somehow providing what we call chemo protection, that it is providing a pharmaceutical protective effect against developing esophageal cancer.
Dr. Chutkan, we're interested in something you've called SIBO, small intestinal bacterial overgrowth. What the heck is it, and why should we worry about it?
Well, first of all, we'll start with the pronunciation, because I call it SIBO, you call it SIBO, but some people call it SIBO, but it's all the same thing. So small intestinal bacterial overgrowth refers quite simply to imbalance in the microbiome. And the microbiome is the trillions of organisms, mostly bacteria, but also viruses, fungal organisms, parasites, all these microscopic organisms that live in and on our bodies and that are incredibly important for our health and well-being. So SIBO represents an imbalance within that microbiome where we see shifts in the composition of the microbiome and shifts that affect our health. Clinically, SIBO is mostly manifest as gas and bloating and burning, sometimes a change in bowel habits where people have more diarrhea, but they're also what we consider extra-intestinal manifestations, which are symptoms outside of the GI tract, and those can include things like brain fog, fatigue, joint pain. So as you can imagine, this is a very sort of non-specific constellation of symptoms. And it's not the kind of condition where there's a simple blood test or there is a breath test, but again, it's fraught with false positives and false negatives. So this is a diagnosis that we really make clinically based on this constellation of symptoms as well as somebody's history, which is crucially important in making the diagnosis. And when we're talking about the history, we're mostly looking at what kinds of medications this person has taken that can cause SIBO, and top of the list are antibiotics and proton pump inhibitors.
Wow. So, there was a time in this country when teenagers who had, a blemish or 3 would be put on tetracycline or some form of tetracycline, not for days, not for weeks, not for months, but for years. And I'm just wondering, what was the impact of taking an antibiotic for that length of time on the bacteria in the digestive tract? And of course, there are other conditions. Lots of women are put on antibiotics for long periods of time to prevent urinary tract infections. I mean, we've been very promiscuous with our use of antibiotics over the last couple of decades.
We have, Joe. And again, nothing is free. And I can't really fault dermatologists decades ago. I was put on tetracycline for acne when I was a teenager, and that was decades ago. Because we didn't know. Nobody knew what the microbiome was really. We knew about it, but it was a sort of murky thing. And we were still in this era of microbes are bad, so we should destroy them. But what we know, and this is, when I think about this, I just want to cringe when I think about the antibiotics that I myself have prescribed as a physician in the past. Now I spend all my time trying to convince people not to take them. But the startling statistic is that 5 days of a broad-spectrum antibiotic, like the kind you would take for acne or a urinary tract infection or a sinus infection, can remove up to a third of your gut bacteria. And there is no way to get those back reliably. Taking a probiotic is a drop in the pan. So anybody who's out there thinking, oh, I'll just take a probiotic and all will be well, it's like emptying a bath full of water and pouring in 1 cup of water and thinking that somehow your bath is full. So these antibiotics are incredibly sort of dangerous for gut bacteria. So they're helpful for pathogens we're trying to kill. And if you've got a flesh-eating bacterial infection or something, they're great. But what we've done is we've started treating problems that are really inflammatory problems like acne. Acne is not a problem of infection. It's a problem of inflammation. And we haven't asked that crucial question, why? Why does somebody get acne? It's a complicated question to answer. But using a fix like an antibiotic that we know is destroying gut bacteria, and particularly in young people where the microbiome is still developing, what we know now is that antibiotic use in childhood or as a teenager can dramatically increase your risk of developing an autoimmune disease later on. We know from a meta-analysis, another large compilation of patients from Mount Sinai, looking at thousands of patients, that childhood use of antibiotics, broad-spectrum antibiotics, and virtually all antibiotics except penicillin, dramatically increase the risk of developing Crohn's disease and ulcerative colitis, 2 very serious autoimmune conditions of the gut in people who are genetically susceptible. So this idea that disease just falls out of the sky into our laps or it's all our genes, we know is not correct. These epigenetic factors, these external factors of the food we eat, the drugs we take, the environment we live in, have a profound effect on who ultimately will develop disease. And so we know that these teenagers and adults sometimes who are on, as you said, Joe, years of tetracycline, but certainly even weeks can do it. But the longer the antibiotic use, the worse. We know that is setting them up for developing real autoimmune disease down the road. And I've said it before and I'll say it again. If you're a dermatologist and you're using antibiotics as first-line therapy to treat acne, I really believe that that's medically negligent, knowing what we know today.
You're listening to Dr. Robin Chutkin. She's on faculty at Georgetown Hospital, and she's the founder of the Digestive Center for Wellness in Chevy Chase, Maryland. She did her medical training at Columbia and is board certified in gastroenterology. She has 3 books, Gut Bliss, The Microbiome Solution, and The Bloat Cure.
After the break, we'll talk more about acne and inflammation.
A lot of chronic conditions are associated with inflammation. Where's it coming from?
We'll also find out about leaky gut syndrome. What do you need to know about reducing intestinal permeability?
You're listening to The People's Pharmacy with Joe and Terry Graydon. If you're enjoying this People's Pharmacy podcast, why not head over to our website where you'll find a wealth of information on medications, conditions, home remedies, and ways to keep yourself healthy. You'll find it all at peoplespharmacy.com.
Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Red X Industries, makers of Utterly Smooth Foot Cream with shea butter, helping dry, cracked feet feel utterly soft and smooth. 800-345-7339. Online at uttercream.com.
To order a CD of today's show or any People's Pharmacy broadcast, you can call 800-732-2334. Today's show is 1078. That number again is 800-732-2334. Online at peoplespharmacy.com.
Today we're talking about your microbiome and why it's so important to your overall health. Should you be concerned about intestinal permeability?
Our guest is Dr. Robin Chutkin. She's on faculty at Georgetown Hospital and is the founder of the Digestive Center for Wellness in Chevy Chase, Maryland. She did her medical training at Columbia, is board certified in gastroenterology, and is the author of 3 books, Gut Bliss, Microbiome Solution, and The Bloat Cure.
Dr. Chuckin, you mentioned that acne is actually an inflammatory condition rather than an infectious condition. So where is that inflammation coming from? So many of the diseases that are problematic now are inflammatory, are cardiovascular diseases, so many of the diseases that really trouble us.
Absolutely. And I try not to oversell the microbiome. You know, when there's a new frontier in medicine like this and you're sort of at the forefront, it's very exciting and it's very easy to sort of become a hammer and think that everything is a nail and everything is caused by microbial discord. So I will say that the microbiome and the imbalance in the bacteria, not just in our guts, but on our skin, is one contributing factor to acne. If we look at other skin conditions like rosacea, for example, another inflammatory condition, sort of a first cousin of acne, we see that there is an imbalance in the skin microbiome, and we see that mites, these certain microbial organisms, are overrepresented. If we look at people with eczema, we see that 90% of them are colonized with a particular form of staph, a certain bacteria that's overrepresented on the skin. And so microbial imbalance is one of the contributing factors. And how does that develop? It develops from all the harsh products, the household cleansers and the personal care products that are full of chemicals and antibacterial that are killing off many of our essential healthy bacteria and creating this sort of microbial discord, what we call dysbiosis. So that's one contributing factor. We know that diet is another major contributing factor to inflammation, and that inflammation can be manifest as cardiovascular disease. It can be manifest as autoimmune disease. It can be manifest as acne or rosacea or eczema or psoriasis or any of these other skin conditions. So really looking for the root cause, which is often multifactorial, and asking that essential question, why? We're very good at saying what. That's what we're taught to answer in medical school. What is this? And here's a pharmaceutical remedy. But we don't spend a lot of time digging deeper and asking why and going beyond just a genetic basis for disease.
Well, that brings me to your axiom, live dirty, eat clean. Can you explain that, please? What do you mean?
I can, and I'll tell you that my 11-year-old loves the live dirty part. She's like, Mommy, I'm not bathing today. I'm rewilding myself and reconstituting my microbiome. So when she gets really pungent, I do have to send her off to the bath, I have to admit. What I mean by live dirty is this concept of rewilding. Rewilding is a term from conservation biology, and it really refers to reintroducing species that are sort of native to a landscape, to the terrain, that have been killed off, usually, by us, typically. And I like this concept of terrain because if we think about Pasteur talked a lot about germ theory, and there was this idea that one bad actor, a bad germ, would get into our body and wreak havoc and cause an infection. And we know that that still does happen, but the more comprehensive and probably more accurate view of how we get sick is because our terrain, our very soil, is off. And it's off because we've taken a lot of antibiotics, we have used proton pump inhibitors, we have used many other things in the medicine cabinet, non-steroidal anti-inflammatory drugs, hormonal therapy, that throw off our bacterial balance and kill off a lot of healthy bacteria and create microbial discord. So we have terrain that is not healthy. And in that unhealthy terrain, then there is opportunity for lots of things that are when they're represented in normal quantities, they're not pathogenic, but when they're overrepresented, they become a problem. They become opportunistic in a way. And so it really is about our terrain and looking at our terrain. And our terrain is not fixed with a pill any more than I love these comparisons to what's going on in the soil and with the garden. So the same way that if you are trying to grow healthy crops, the idea is not that you don't sort of test and replace and see, okay, I have to add more nitrogen, I have to add more carbon, I have to add more hydrogen. You look at the soil overall and you think, how can I avoid using pesticides and things that are going to damage your microbes in the soil? How can I create a closed loop biodynamic farm where the animals are providing fertilizer for the crops and then the crops are going, the animals are eating them and refertilizing. So looking at our body that way, how can we rewild our bodies? How can we stop killing off both internally and externally these essential microbes and have a more cordial relationship with them, quite frankly.
Well, let's get very specific, Dr. Chutkan. What are you recommending to your patients? You know, the people who come in and complain about irritable bowel syndrome and all kinds of other symptoms that are making their life really quite unpleasant. What do you say to them in terms of diet, in terms of probiotics, other kinds of dietary supplements? I mean, give us some news we can use.
Sure, absolutely. So the first thing we do is I really counsel them about judicious use of medication. And when we can, which is most of the time, we get rid of the acid suppression, the hormone replacement, the antibiotics, and then NSAIDs and so on. So we take a good look at what I like to call the menace cabinet, because that is often where disease springs from. Then we look at their diet, and what I recommend is something that I call a Velio diet, which is a combination of a vegan and a paleo diet. Paleo in the sense that removing some of the processed carbohydrates, which are metabolized and broken down into sugar, and which tend to promote growth of unhealthy bacteria. But vegan in the sense that what do good gut bacteria like to eat? They like to eat indigestible plant fiber. So we did a study in our patients with inflammatory bowel disease who were on a paleo-type diet, and we found that most of them got better, but there was a distinct group that didn't. And we could very clearly correlate that with the amount of servings of vegetables. So if you cut out most complex carbohydrates, you can end up eating bacon and eggs for breakfast, chicken for lunch, and steak for dinner, and no vegetables on your plate. And those were the patients who really didn't do well. So despite the fact that they had taken out the gluten and the sugar and all that stuff, they still weren't doing well. So when we really encouraged people to increase the servings of vegetables to somewhere around 6 to 9 servings of vegetables a day, we really saw dramatic changes in the rate at which they were getting into remission and staying in remission. So in terms of the diet, removing the processed stuff and the stuff with a long shelf life is important, but it's equally important to eat more plants. And I think Michael Pollan, his 7 words, said it the best. Eat food, mostly plants, not too much. But I would add to that, make sure they're grown in dirt too, because that's where we get our microbes from as adults, is the food we're eating and the richness of the soil that it's grown in. So eating more plants, I have what I call the 1-2-3 rule, which is 1 vegetable at breakfast, 2 at lunch, 3 at dinner. In my own life, I reverse it to 3-2-1 because I have a green smoothie most mornings. And so I just get my 4 or 5 servings of vegetables over with in the morning. But the diet is incredibly important, not just eliminating, but also adding in. In terms of supplements, I'm not a huge supplement fan. I do believe in a robust probiotic for people who need it, but I really don't think that the average healthy person needs to take a probiotic any more than they should be taking a vitamin. There's just really not evidence to suggest that our health can be improved beyond the things that we can do with diet and lifestyle by taking a probiotic. But again, the population I deal with tend to have specific gastrointestinal conditions, whether they have Crohn's or ulcerative colitis, irritable bowel syndrome, etc. So in that population, there often can be benefit for a well-chosen, robust probiotic that has enough strains in high enough numbers working synergistically together to actually do something.
Dr. Chutkan, I had an opportunity to hang out with some absolutely wonderful physicians about 1.5 years ago. I mean, kind, compassionate, thoughtful doctors who really care about their patients and who try to stay up with the literature. But somehow the conversation started around leaky gut. And these docs, who are phenomenal, started laughing and making fun of the concept. In fact, there's a name for it. Some gastroenterologists actually call it.
They call it intestinal permeability, which sounds much more medically acceptable.
But these doctors just thought this was hokey pokey. This made no sense. This was quackery. And, where in the world did leaky gut ever come from? I didn't learn about it in medical school. So can you clarify, is there such a thing as leaky gut? And what can you do about it?
There absolutely is. And let's start with that sort of town-gown divide, if you will, between more holistic healthcare practitioners and conventional doctors. Part of it is that these things were not taught in medical school because nobody knew anything about them in medical school. I'm about 25 years out from medical school, and certainly that's not a term that was bandied about. And the continuing medical education that physicians get is mostly pharmaceutically driven. So it's about new drugs. So physicians are a little bit late to the game, but what leaky gut refers to is this concept, as Terry mentioned, of intestinal permeability. And I want you to think of the lining of the gut as a fishing net. It's obviously porous because when you eat, things in the GI tract are not actually in the body. They're in this hollow tube that goes from the mouth to the anus. That's sort of a hollow conduit through the body. So when you eat food, how does it get from this hollow tube known as a gastrointestinal tract into the body? How does it actually get to the cells that use this food for energy? It gets there by diffusing passively and actively through the gut lining, which is this permeable fishing net. So in its healthy state, the lining of the gut is a fishing net with very, very tiny holes. And food has to be broken down into its constituent parts, and protein and fat and carbohydrate, and bile is used to help to make fat soluble. And so it passes through, and some things pass through with carrier molecules, some things pass through passively. But that is the intestinal permeability. We know that intestinal permeability can be increased by certain things. And I'll give you an example, non-steroidal anti-inflammatory drugs. When you take ibuprofen and you get an ulcer is a hole in the lining of your GI tract. And we see it crystal clear on endoscopy. We see literally a hole. But these drugs also cause microscopic holes that increase permeability. And antibiotics can do that. And parasitic infections can do that. It's like holes in the fishing net that haven't been repaired. And what that creates is an increase in intestinal permeability where larger particles that normally would be kept out of the net because of their size can now pass through, get into the bloodstream, signal the immune system, and create problems. And it is a basis for a lot of food allergies. When I see people coming in with a list sometimes of dozens of things that they can't eat, not the usual nuts and corn and eggs and the common things, but, almost anything they eat causes a reaction, causes hives, joint pain, brain fog, headache. Those patients are not making that up. They're not crazy. Those are real symptoms. They don't have a real explanation for it, but these are real phenomena. And leaky gut is more of a mechanism than an actual disease. It is a mechanism and a way in which particles, viruses, poorly digested food particles, toxins, all kinds of things access the body through the GI tract and really create an immune reaction within the body. And what's really fascinating now, Joe, is that very well-regarded researchers, like, for example, Al Fasano, who's probably in the U.S. the most well-regarded researcher for celiac disease, have absolutely acknowledged and embraced this idea of leaky gut and says this is a real thing. So I think it's really a matter of people being misinformed, quite frankly, and not keeping up with the medical literature, this scoffing at things like leaky gut or yeast overgrowth. And I don't understand it because, for example, when a woman takes an antibiotic or takes several antibiotics, she frequently will get a yeast infection, and it's very clear. But yet when people come in talking about yeast overgrowth and we can see the red yeasty discharge in their ears and on parts of their skin and in their groin, conventional doctors still tell people that they're somehow making this up and this is not a real phenomenon. So I think we all have to do a better job at being better informed and not relying on what we learned in medical school 25 and 30 years ago.
So is there anything people can do to reduce their intestinal permeability so that they won't experience problems?
Absolutely. I focus on removing the offending agents. That is a most important thing because no matter what, whether you're taking a zinc and a glutamine supplement or you're using curcumin, turmeric or, whatever you're doing, if you are not removing the offending agent, which is usually a pharmaceutical agent or sometimes a food, you are not going to get better. So, for example, we know that alcohol can increase intestinal permeability in large amounts. Alcohol is metabolized to acetaldehyde, a first cousin of formaldehyde. It's toxic to gut bacteria in large amounts. So if you're drinking a couple glasses of wine every day and you suffer from leaky gut and you maybe have an autoimmune disease, that's something you have to look at changing. So yes, there are supplements that can be helpful, but it really fundamentally boils down to trying to remove some of these offending pharmaceutical agents and really changing your diet.
Dr. Robin Chutkan, thank you so much for talking with us on the People's Pharmacy today.
You're so welcome. It was a pleasure to be with you.
You've been listening to Dr. Robin Chutkan. She's on faculty at Georgetown Hospital and is the founder of the Digestive Center for Wellness in Chevy Chase, Maryland. She did her medical training at Columbia and is board certified in gastroenterology. She's the author of 3 books, Gut Bliss, The Microbiome Solution, and The Bloat Cure. You'll find links to her website at peoplespharmacy.com.
We spoke earlier with Dr. Philip Gorelick, speaker for the American Heart Association. He's the medical director of the Hauenstein Neuroscience Center at St. Mary's Healthcare in Grand Rapids, Michigan. He's a professor of translation science and molecular medicine at Michigan State University, and you'll find a link to the article he was discussing on our website.
A word of caution. No one should ever stop any prescribed medication without first discussing the situation with the prescriber. Discontinuing a PPI suddenly can lead to rebound hyperacidity and severe heartburn symptoms.
Lynn Siegel produced today's show. Al Wodarski is the engineer. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is made possible by Redix Industries, makers of Utterly Smooth Extra Care 20 Cream with 20% urea for extra skin protection. The number's 800-345-7339. The website is uttercream.com.
If you'd like to purchase a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1078. That number again, 800-732-2334, or you can place the order online at peoplespharmacy.com.
When you visit our site, you can check out information on prescription drugs, herbal medicines, and home remedies. Share your thoughts on today's show. What do you do for heartburn or other digestive upsets? We'd love to have your feedback.
At the website, you could also sign up for our free online newsletter or the free podcast of the show. That way you can listen at your own convenience or share it with a friend. It's all there at peoplespharmacy.com. And why not become a friend of the People's Pharmacy on Facebook?
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening. Please join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.